to do a little inspection on the back, just to make sure there's not anything like lesions, scars, anything like that, anything that would get in the way of the nervous scope. Next, we're going to turn the nervous scope on. We're going to set the sensitivity to medium. We're going to close the endings for the cervical spine. And what we're going to do is we're going to keep it perpendicular to the skin, and it should leave a little bit of dimpling in there. And we're going to go up. And then whenever we find a break, the break it'll have a sharp pull on the needle, and then we'll go over that area 3 times. And then for the cervicals, we're going to mark it on the bottom of the trailing end. Next, we're going to open up the nervous scope all the way for the thoracics. And now we're going to be going down the spine. And then whenever we find a break, we're going to go over that area 3 times. And on this side, we're going to mark it on the superior end, which is the trailing end. All right. Palpate the spine for any edema. And it doesn't look like I see any. But if there was edema, it'd be kind of squishy and boggy in that area, which would indicate subluxation. Next, I'm going to assess the occiput. So I put my if in between the C0 and C1 area, and we're going to bend it, and that should close down on my finger. If not, say if the right side over here didn't close, that'd be the side of laterality, and that would be the side we'd be interested in. Next, I will check P to A glide. So I'll come through here like this, and it should move nice and easy. Good. Next, we'll do Atlas. So I'd put my finger inferior to the mastoid process, and then basically we'll rotate him, and that TVP of Atlas should move forward. If it doesn't, that would be the side that we would be interested in. And then next, I'll do lateral bending as well. And the C1 and C2 joint should close on my finger. If not, that'd be the side with subluxation. Next, we'll do all right, so now we're going to assess the thoracic. So we'll go to T6. So I'm going to have the patient bend forward. All right, and come back. So on the flexion, the spinous processes should open, and on extension, they should close. If not, we'd be interested in the segment above, which would mean it'd be posterior. Next, we'll have them rotate, and the spinous processes should go along with my fingers. If not, that would mean the thoracics would be PL or PR. And then next, we'll go into lateral bending, and we're feeling for the curvature in the spine. And he has good curvature. If not, that would indicate which side the wedge would be on. Next, we'll go to PSIS. All right, go ahead and cut it. All right, so now I'm going to rotate the patient, check for the SI joint, see if there's any movement in here. And if I don't have any movement, that would indicate a subluxation, which would be a EX or IN. I don't know, to be honest. All right. All right, now I'm going to have you raise your right leg. And on this, the joint should close. If it doesn't, that would be an AS. And then go ahead and raise your opposite leg. And that joint should separate. And if not, that would indicate a PI. Keep your eyes closed the whole time. Okay, good. So he's looking pretty straight. If he was looking more up, that would mean a AS. So Atlas went superior. And if chin was down, that would be a AI. All right, next, we will assess glute width and glute height. So for glute width, we're basically just going to go up. Glutes should be about the same. They should be the exact same, which they are. If they weren't, go ahead and pause it. Or excuse me. Width? No, height. I was right the first time. And then the side that's a little bit more superior would be an AI, and the side that was lower would be a PI. Next, we'll do glute width. So we'll go to that cleft. All right. And the narrower glute would be a IS, and the wider one would be an AS. C1 is internalize the leg, and on this, if the joint doesn't close, that would be a IN, and then we'll push it in, and it should spread apart, and if it doesn't, that'd be an AS. Next, we're gonna pull the leg out, and if it doesn't approximate, that would mean that it's a EX. And then I'm gonna push the joint in, and it should space out. And if it doesn't, that means it's gonna be an IN. Is that right?